Hello, thank you for joining us. This is Betsy Berry. I'm the clinical lead for the Cardiac Care Network of Ontario for cardiac surgery, arrhythmia, and TAVI. We'll be talking today about implantable cardiac devices and give you an overview. So four main objectives of this presentation are first to give you an overview of the basic functions of these devices, both ICD and CRT, what populations are receiving them and why, practical tips when caring for your patients with these devices, and some considerations for end-of-life planning. So as I said before, there's two different types of devices, an ICD and a cardiac resynchronization therapy device. CRT devices are further divided into a CRT-D. When you see the D, it's denoted that it has a defibrillator as well as pacemaker functions, and a CRT-P indicating pacemaker only functions, so therefore no defibrillator, pacing only. So a few terms that you'll hear out in the field is whether similar to a pacemaker, whether a patient has a single chamber device or a VVI, V meaning there's one single lead in the right ventricle, dual or DDD indicating there are two leads, one in the top atrium and one in the bottom in the right ventricle. We all know that pacemakers treat slow heart rhythms or bradycardia, but what's special about defibrillators, ICDs and CRTs, is that it can also overdrive pace or deliver painless pacing in case there's an abnormally fast heart rhythm. All ICDs, importantly, and CRTDs have both capabilities of pacing as well as defibrillation. The main components of a device are the pulse generator, or the CAN. You'll hear that called the CAN, and it's the main component or the brains of the device and contains the lithium battery. And the other component are the leads. This picture depicts a pacemaker and an ICD. So in the top left corner, you'll see that this is a pacemaker. It's very thin in comparison to the other two devices, which are an ICD and CRT device. Just to note the different footprint, and you will be able to see this underneath the patient's skin. So what do the leads look like? There are a variety of leads. Most likely for a defibrillator patient, you will see an active fixation lead. This lead is to the far left with the red arrow. You'll see the screw at the tip. This screw actually is deployed into the right ventricle to stabilize it, and it can also be used in the right atrium. To the far right is a defibrillation lead. You'll notice that the yellow arrow is pointing to the defibrillation coil, which is quite thick in comparison to the pacemaker lead at the far left. In the center is a passive fixation lead, meaning there is no active screw going into the tissue, but rather soft tines that get caught in the right ventricular trabeculi. Device location for pacemakers or defibrillators is very similar. Typically on first implant, devices are placed on the left side of the chest, right under the clavicle, and the leads are inserted transvenously through the subclavian vein, and the leads are fed into the ventricle. The ventricular lead going in first to provide pacing, and then a right atrial lead if a dual chamber device is implanted. So we talked about the two main components of any device, which is the CAN or the pulse generator and the leads. This is just showing you the device and the lead location close up. There's another type of ICD out there called a subcutaneous ICD. There are a few manufacturers now. And this is just a shock box, basically. It has no pacing functions. You'll see this in the younger population that have various arrhythmias such as Brugada or long QT syndrome. So why do people get an ICD? Well, the main reason is primary prevention. So this cohort of patients has not had an arrhythmia, but they are deemed at risk. So we know that patients that have coronary artery disease, have had a prior MI, and have reduced ejection fraction are at risk for sudden cardiac death. As well, a secondary prevention patient, these patients have already have had a sudden cardiac arrest and have been resuscitated, so they are considered secondary prevention. Just to note that when we implant a defibrillator, it doesn't affect quality of life as it will in a CRT or resynchronization therapy device, and we'll talk about that in a bit. But this is just mainly to prevent sudden cardiac death. So the device can treat ventricular arrhythmias in two main ways. One is to pace faster than the underlying arrhythmia, and we call that overdrive or anti-tachycardia pacing or anti-tachy pacing, you'll hear. And that typically can get the patient out of an arrhythmia painlessly. If that doesn't work or the rhythm is too fast, depending on the individual patient's settings, the device will deliver a high voltage shock. So I want to set up a video that I'm going to show you, and the purpose is if you see a patient in the field getting a shock, this is what you'll see. This video is a patient having an implant, so we're actually in the operating room, and what they can do at times is test the device to see how the device would react and if we can get the patient successfully out of the arrhythmia. So note, I want you to look at the laptop programmer. It looks like a laptop, and look at normal sinus rhythm. What's going to happen is the person is actually going to induce ventricular arrhythmia by a shock on T. So you will see the patient get an initial shock. You'll see the rhythm go into ventricular fibrillation, and several seconds later you'll note the device actually delivering the shock and returning the patient to normal sinus rhythm.
Here we're going to do a EP study for T-shock. Shocking T at 1.2 joules.
Okay. So
first therapy will be from the device at 25 joules, second therapy will be 35, third therapy will be from external defib. Okay, enabling now. So everyone's ready. Charging. Pacing train, T-shock, hip sense, hip detected, charging for 25 joules, charge delivered, back to sinus.
Okay, good.
Right.
So we talked about an ICD, and now I just want to introduce you to the cardiac resynchronization therapy device, which is a heart failure device. This is unique because we want to pace both the right and left ventricle. And I want to bring your attention to number 6, and this is the lead on the left side of the heart. It is not inside the heart, it's actually sitting in the left lateral vein. That lead is positioned so that the right and the left ventricle can contract at the same time. So an indication for a CRT device, these patients have had medical therapy optimized, and they are still having symptoms. So we want to go ahead and put in this device to hopefully bring their QRS to a near normal duration. And this will help improve contraction and forward flow. So why do people get a CRT device? Again, I mentioned it's about quality of life. So if the patient has a risk of sudden cardiac death, they would put in a CRT-D or defibrillator device. And if it's simply to improve the quality of life and in symptoms, they can get a CRT-P or pacemaker only. So no shocks, but at least hopefully the symptoms of heart failure will improve. This is an example of what a device looks like on X-ray. The top right, you'll see the pulse generator or the brains of the device. You'll see 3 leads exiting the top of the device, and to the left is the lead in the right atrium, and that's an active fixation lead. We can vaguely make out the screw coming out the tip. The one with the 2 thick parts on it, the lead and the right ventricle, those are the shocking coils, so we know that that's a defibrillation lead. You wouldn't see that thick coil on a regular pacemaker lead. Note to the far right, the lead in the left coronary vein. You see 2 black dots, and that's the tip of the left ventricular lead. Again, looking at the CRT device on X-ray, we can see what it looks like at a distance, and we can see the pulse generator and again the 3 leads exiting the top of the device. This is an interesting case. Some patients, they have multiple devices implanted. Unfortunately, this individual has a pacemaker on the left and also has an ICD implanted on the right. And it's not only an ICD, it's a cardiac resynchronization device. So what we can tell from this picture is, from the sternal wires, we can tell that this patient has had a previous cardiac surgery. We can see 2 J-shaped leads that are in the top atrium. We can see a lead going to the left lateral side of the heart, which is to the right of the picture. And we can see 2 leads in the right ventricle. One that has the 2 thick parts is the defibrillation lead. So there are 11 sites in Ontario that are specialized cardiac implant center of both ICD and CRT devices, and they're listed here. They're also listed as well as their phone numbers on the Cardiac Care Network of Ontario's website. So these devices are followed up mostly in person, but they can be followed up remotely. So when a patient comes into clinic, we're looking at the lead functioning, and we do that by testing how much voltage is required to capture the heart. We're looking at the lead impedance, which may indicate a break in the lead. And then every beat is looked at, and if a patient has an abnormal rhythm, the ECG is stored. So we look at that. We look at if any therapies were delivered and were they appropriate. Especially in the first early stages, we're looking at the access site and making sure that there's no infection. Device battery life ranges from 5 to 8 years. The heart failure device needs to be 100% paced, or as close to 100% paced as possible. So this device, of course, has a shorter longevity than an ICD that may be implanted for primary prevention and is just sitting and watching. This is an example of the remote monitoring systems offered by all the companies. So all the companies have their associated remote monitoring device. This can be done trans-telephonically or wirelessly. So the patient activates the system and downloads the ICD or CRT information to the clinic where the the ECGs and the parameters are examined. If there are any problems, the clinic notifies the patient to come in and be looked at in person. So what are some practical tips for caring for your patients with these devices? So patients are advised at implant to always carry an ID card. This ID card from the manufacturer shows the patient's model and serial number, as well as gives the technical services information line for both patients and healthcare providers. They're also advised to wear a medical alert bracelet in case of emergency. Cell phones are permitted to be used. We just advise that the cell phone is not carried in a breast pocket, for example. It should be at least 6 inches away from the device, so use the phone on the opposite ear of implant. Large motors, for people that are working on engines, they emit a magnetic field that may inhibit pacing, so that is not advised. Patients are able to travel and go through the anti-theft systems. When traveling, just notify the screener that they need to be inspected by hand. Don't use a heating pad directly over the device, and avoid high voltage systems such as arc welding, and of course protecting trauma from the chest. If trauma does occur, they should go to the clinic and have their device interrogated and make sure that everything is working appropriately. So some patients are undergoing chemotherapy and also have their device. This can cause an increase in the need of the voltage to be turned up in order to pace. So we advise our patients, if they're undergoing chemotherapy, to let the clinic know so that this can be monitored more closely. A lot of devices now are MRI compatible. It will say this on the card that it's MRI compatible, and if not, technical services should be advised, or call the implanting center and let them know. Mammography is fine. Therapeutic ultrasound, again, the rule of 6 inches away from the device. And again, please call the implanting center and talk to the healthcare providers if there are any further questions. So end-of-life planning and ICDs. End-of-life care and goals of care should be discussed prior to the time of implant. These conversations should also occur when there are changes in healthcare status, the health of the patient, and really to ensure that the device is wanted, so that shock therapies can be turned off if the patient desires and it's no longer required as part of their goals of care. The pacemaker therapies always remain activated or on. So there are a couple of decision points or triggers about when to talk to patients about their device and potentially turning off the shock therapies. Again, always prior to implant. This conversation occurs with the physician implanting. Anytime it's requested for more information by the patient and family, of course. At the time of replacement, so when the battery is depleted, so in 5 to 8 years when that battery needs replaced, it should be discussed. If the patient is having multiple shocks, is the disease progressed to the point where this therapy is no longer wanted? Again, change in clinical status could be cancer, for example. Repeated hospitalizations or emergency room visits for heart failure. The heart failure is getting worse. And the cardiac symptoms are refractory despite optimal therapies. Additionally, if a patient is deemed ineligible for advanced therapies such as transplant, they no longer have the quality of life that's desired. they have a presence of a DNR order. We see that a lot still, that patients do not want to be resuscitated. However, their shock therapies are still active. And then if they're referred to hospice or nursing home, it should be reviewed at that time, and minimally at least annually when they come in for their ICD clinic visit. So an ICD is deactivated in two ways. The first is to use a specially trained computer, the laptop computer. Each manufacturer has their own specific one. And of course the trained healthcare professional that's part of the implant team or healthcare providers in the implanting center. The other, in an emergency, and you may see this more often, is a medical grade magnet that's taped in place over the device. So just a reminder that a magnet is only used in emergency situations, and that deactivation with a programmer is desired and needs to be done as soon as possible. The weight of this magnet against the skin can cause skin breakdown. So what are some common myths about the ICD and shock therapies being deactivated? Some have likened it to euthanasia or medical assistance in dying. The intent of the device deactivation does not hasten death, but this is about avoiding painful and unwanted shocks and quality of life. The patients think they need this device in order to stay alive, and without it their heart would stop. So again, reassuring the patient that turning off the shock therapies will not cause immediate death or hasten death. We want to make sure that in the situation where an ICD is actively delivering shocks repeatedly for life-threatening arrhythmias, we know that at that point, if the device is disabled, death may occur imminently. Deactivating the device is non-invasive, so it's done by the programmer that we just saw, and it's quick and painless. So more ICD deactivation myths. Remember that the shock portion and the pacemaker portion are separate parts of the device that are programmable independently, so that we can turn off the defibrillator portion and the pacemaker function remains active. If you touch a patient while the patient is receiving shocks, you may feel some tingling. If you're doing CPR, which we'll talk about in a bit, the wearing of gloves will help prevent that sensation to you, but it will not result in harm to you. So turning off the shocks, so just because we turn off the shocks, this is not permanent. It can be turned back on simply, non-invasively, just like we turned it off, we can turn it back on. So that decision, if the patient improves, it can be done. The medical grade magnet is required to turn off the device. It can't be any magnet. Most emergency rooms should have them, and we're advising that nursing homes and palliative care homes should have them as well. Some manufacturers, the magnet needs to be taken off and reapplied to the skin. But if the magnet is taken off permanently, the device will reset itself and the shock therapies will be resumed. So CPR on the device patient. Can I perform CPR? Absolutely. You can perform CPR. The device will be delivering shocks. If you want to place, you will be placing external defibrillation pads, and that's perfectly fine. Just don't place the pads directly over the device. It's preferable to use anterior-posterior, but if you can't do that, placing the anterior one as close to the sternum on the opposite side of the device and under the apex of the heart is sufficient. Will I get shocked? We said that yes, you may feel something. It's not going to hurt you. You may feel a sensation, but again, wearing those gloves will help prevent that. So post-mortem care, if you have a patient that dies and has the ICD still activated, that healthcare professional needs to come preferably to the place where the patient is prior to going to the funeral home to have that device deactivated. In most cases, the patient can be buried with their ICD, except if they're cremated. If they are cremated, the device must be removed. This is an explosion hazard and can cause damage to the crematorium as well as the staff. It's advised that devices are returned to the manufacturer for analysis. So in summary, there are a few choices for a patient for therapies, whether it's a pacemaker, a heart failure pacemaker, heart failure defibrillator, CRTD, or an ICD, whether it's a single chamber or a dual chamber. It depends on the clinical indications and, of course, the goals of care. We know that pacemakers treat slow heart rhythms and that both ICDs and CRTs have both pacemaker and defibrillator capabilities. But importantly, end-of-life planning needs to be considered all through the life of the device, and these conversations need to be ongoing.